A very warm good morning to everybody joining us online today for the webinar on improving outcomes for First Nations people. We are presenting to you from Larrakia Country, Darwin Northern Territory, and specifically the Alan Walker Cancer Care Centre here at the Royal Darwin Hospital, our largest hospital in the NT health system. We have gathered perspectives from our medical oncologists and our clinical trial nurse coordinators on some of the experiences we've had and barriers to recruitment and ongoing participation of our Indigenous patients in cancer clinical trials here in the NT. Thanks for joining us. I would like to acknowledge that this presentation is being streamed from the traditional lands of the Larrakia people on this Gurulwa Gulagi Day. We would like to pay our respects to elders both past, present and emerging and recognise the special connection the Larrakia people have to their country on which we speak to you from today. The Alan Walker Cancer Care Centre at Royal Darwin Hospital is part of the top-end regional health service of NT Health. NT Health has 5 regional health services: Top End, East Arnhem, Big Rivers, Barkly and Central. And whilst our geographical area is large, we only have just over 200,000 residents. Of these, 30% approximately identify as Aboriginal or Torres Strait Islander, and this is reflective of 9.3% of the national Aboriginal population. The Alan Walker Cancer Care Centre itself is an outpatient medical oncology, haematology and radiation oncology day treatment unit located on the grounds of Royal Darwin Hospital, which is a 360-bed public hospital and is our largest and only tertiary referral hospital in the Northern Territory. The Alan Walker Cancer Care Centre here at Royal Darwin has been open for just over 12 years. We now have 5 permanent medical oncologists, also 5 haematologists, 4 radiation oncologists, and we have expanded in recent years from a 12-chair to a 20-chair day treatment unit. We are permanently staffed with 2 specific Alan Walker Aboriginal liaison officers. We also have 12 full-time tumour stream cancer care coordinators, and we have a whole allied health multidisciplinary team specific to cancer services as well. The Oncology and Haematology Clinical Trial Unit at the Alan Walker Cancer Care Centre is the most established clinical trials unit at the Royal Darwin Hospital, with its 23 ongoing trials representing 43% of all clinical trials across NT Health. Coordinating these 23 trials are 2.5 full-time equivalent RNs and 1 full-time admin officer working alongside the principal investigators on site. Our trials unit recruited its first patient to trial participation back in 2011, and today there are over 239 patients participating in 23 ongoing clinical trials. Of the 239 patients currently participating in the 23 trials at Alan Walker Centre, only 6% of these patients, or 15 actual patients, identify as Aboriginal or Torres Strait Islander. Our recruitment of Aboriginal patients to clinical trials at the Alan Walker Centre is quite low, and some of the barriers to recruitment from the literature that is most relevant in our setting is the strict inclusion criteria, which does exclude some of our Aboriginal patients, and the limited consideration of cultural aspects of life in trial designs, which is quite relevant with most of our Aboriginal patients being from remote communities or clinics. The other barriers are definitely the language and communication problems, where the patient information consent form is very complex and in-depth, and a lot of our patients have poor health literacy. And also the trial information conveyed in medical language is also difficult to understand, even just the actual diagnosis of cancer and what that means for the patient is often a hard concept to explain for some of our patients.
Is the patient information and consent form itself. So can be anywhere from, again, a 10 to 20 page document. And for anyone with really good health literacy, it's still a difficult document to navigate through. There's a lot of information in there. And I understand from a trial perspective that's really important information. But when you're talking about Aboriginal patients with not so good health literacy, that document is just too difficult to navigate and overwhelming, and potentially they're not even going to be able to read through it at all.
Experience with the informed consent process for the Indigenous population is one where it's very checkered in that, from what I've seen and observed, that there's a lot to be desired in terms of getting the message of the project across, getting that informed discussion happening appropriately. I feel that there are holes. I feel like that the communication is been quite poor at times between the medical staff, the sort of clinicians, and the participants. And this is just my experience. I've been involved in other discussions and other informed consent processes where things have worked fantastically well. Things have flowed and worked beautifully. And you walk away thinking that the process has been done well, the participant is well informed, as are family members, and you can walk away with that knowledge.
The experience that we have had so far with cancer patients in Northern Territory is not, in terms of clinical trials, is actually not much different from the experience that we have had in providing general cancer care. And we have observed significant disparities in providing cancer care in Indigenous population as compared to the non-Indigenous population. And it stems from the cultural differences and the education disparities that we see, and of course, the beliefs that they have in Indigenous population about their land, about how they feel towards their own population, towards their own society, and towards the definition of health, or towards the perception of well-being in general is quite different than the non-Indigenous population. The first barrier is, of course, the challenges towards the understanding of the cancer and the cancer care and the clinical trials, of course. And the other main barrier would be the remoteness of the population or where they live.
We recently started participating in a national program recruiting patients remotely to enable them to access genomic testing. And we soon realised that it wasn't going to work for Aboriginal patients to try and recruit them over the phone and enrol them. So what we've managed to do is negotiate with the sponsor. We're actually going to be set up as a site here in Darwin to enable these patients to be consented face-to-face and have their screening assessments done here face-to-face as well, just to ensure the process is as easy for the patient as possible and that they really understand as much as possible what is.
As is the case with many other diseases, cancer and pathophysiological concepts such as circulation and cells are not words that traditionally exist in Aboriginal language. There are also over 100 traditional Aboriginal languages across the Northern Territory health regions, and also varying levels of health literacy. So the answer to improving outcomes for First Nations peoples and Aboriginal recruitment to clinical trials specifically is not as simple as translating resources into the different Aboriginal languages and dialects. It is also quite clear through Northern Territory specific research that the use of interpreters alone in addressing barriers of communication between clinicians and Aboriginal patients is not enough. We know that through this research that translating alone in education and consenting patients are not adequate in supporting the patient's understanding and autonomy to make an informed decision about their health or care. Further research also identifies that creating meaningful local analogies to create depth of meaning and building health literacy of cancer in a way that makes sense with the patient's lived experience and worldview is essential. So our answer to addressing and improving outcomes for First Nations peoples and Aboriginal recruitment to trials at Alan Walker, specifically, we have looked more broadly across actions we can do to improve health literacy of our patients across cancer care and cancer treatment in the first instance, before building upon this to then introduce them to the idea of recruiting to clinical trial participation. So to do this, we have a patient education folder that we are adapting into a version specific for Aboriginal patients, using local analogies to contextualise and define the terminology and improve health literacy for the patient, their family members and their communities. We're building upon this by developing audio and visual resources reflective of this too, as we know that hard written words aren't going to be as effective as the visual image and the analogies. And then the follow-up to this would be a specific clinical trial recruitment resource to communicate the value of participation for that patient specifically and the community overall. And we believe this work is essential foundational work that ties into improving outcomes for First Nation people. And it also ties in with other works and discussion with other national bodies and interstate partners that are interested in developing an Indigenous consenting tool for clinical trials and Aboriginal patient recruitment. I'd like to introduce Darren Germain, a clinical trial nurse coordinator here at the Alan Walker Cancer Care Centre, who will be participating as a panel member following today's presentations. Thank you.